When you focus on someone's disability, you'll overlook their abilities, beauty, and uniqueness. Once you learn to accept and love them for who they are, you subconsciously learn to love yourself unconditionally. Yvonne Pierre. According to Julie Grisel of laborguide.co.za, employers are often frustrated by employees who don't seem to cope and who do not pull their weight operationally. This could lead to resentment by co-workers and reputational embarrassment. The problem will not go away by itself. The employer must take the initiative. Most workers in South Africa often find themselves answering for cases in disciplinary hearings or dismissed due to poor management of their medical incapacity cases by their employers. The truth is, most of the time, employers do not even know when to begin navigating this complex situation that may have devastating effects on both the livelihood of the employee and productivity of the workplace. Tonight, we approach this difficult subject in honor of all workers whose hearts and minds are willing to commit to their vocational responsibilities, but are simply failed by their physical and mental abilities to remain productive and provide for themselves and their families. Good evening, colleagues. Occupational Health and Exposure Sciences Academy welcomes you to yet another installment of our monthly webinars that are meant to empower us as professionals, to protect our patients who are also employees, and to support employers to remain productive. Welcome. I'm Dr. David Mkwanazi, occupational medical practitioner, travel medical practitioner, ergonomic risk assessor, and exposure scientist. I'm also a health professional educator in training. Colleagues, for those who are regulars on our webinars, kindly please note that we have a permanent link that never changes, and you do not have to test it by joining each time we have a new webinar. This link will be valid until our last webinar in December. Thank you. Just a couple of house rules, colleagues. This session is accredited for 2 clinical CPD points by HPCSA. If you have been with us from the beginning, by the end of this session, you will have accumulated a total of 11 CPD points as we continue counting. Kindly please drop your HPCSA number, full names, and email address in the chat box to register for CPDs. For those who are not registered with HPCSA, an attendance certificate will be issued. Please keep yourself muted at all times to avoid interrupting the presenters. This session's attendance will be monitored for the entire duration of 2 hours. Kindly please ensure that you do not join using nicknames or aliases to be properly identified. Each session will be podcasted on YouTube for long-term education and training purposes. We have realized that a lot of colleagues go back to our YouTube page to recap on information that may have been missed during our sessions. In the future, we will also add Q&A videos for questions missed during our sessions. We thank you for your continued support in this regard. The link and CPD questionnaire can be accessed on www.ohesa.co.za under webinars for those who wish to earn CPD points after watching the podcast. 70% pass mark is required to obtain these 2 CPD points. Participants will be allowed to ask questions or comment after each session. Questions can be posted in the chat box anytime during and after the presentations. You may also contact us for any information or questions after the webinar. Our email address is ohesa.dlp@gmail.com. Sit back and relax. The webinar is about to start. In today's session, we'll discuss labor relations aspects concerning medical incapacity. We will then discuss nursing and medical management of incapacitated employees, and then discuss functional capacity evaluations, and then close off with insurance and benefits that incapacitated employees are eligible for. Most importantly, our panelists are here to help to answer the 20 frequently asked questions that we have around this important subject. Today's session is proudly brought to you by Corporate and Industrial Medical Consultants and Occupational Health and Exposure Sciences Academy. We express our most sincere appreciation to the University of Johannesburg, Rock, Paper, Scissors, Occupational Therapy, and PPS, institutions that are currently employing our panelists and with which they are affiliated. Occupational Health and Exposure Sciences Academy was founded with the sole purpose of bridging the gaps between different occupational health professional fields and making sure that we all speak the same language and approach workplace problems comprehensively and collaboratively. Obviously, for the safety of our workers and patients, empowerment of ourselves and productivity of our workplaces. Colleagues, it is indeed a great pleasure for me to welcome our full female panel ahead of National Women's Month. Our first panelist of the evening is Ms. Incapacity Tole. She holds a BTech in Labor Relations. She is currently an Employee Relations Officer at University of Johannesburg. She was previously the Assistant Director at Labor Relations at Kimberley Hospital Complex and an Employment Relations Coordinator at University of Zululand. Our next panelist is Sister Margaret Langeveld. She's an occupational health nursing professional from 2009. She's currently the occupational health nursing practitioner and travel nurse at University of Johannesburg. She's a member of South African Society of Occupational Health Nursing, and previously she was an occupational health nursing practitioner at AfriSem and Northwest University, also known as Noordwest Universiteit. Our next panelist is Ms. Nicole Debris. She holds a BSc in Occupational Therapist at WITS. She's an OT and director at Rock, Paper, Scissors Occupational Therapist since 2011. She has experience in psychiatric environment and medical legal assessments, including functional capacity evaluations. She's guest lectures at WITS University for undergraduate programs. Lastly, let me introduce Ms. Rebecca Sekhaulelo, who holds a BA Corporate Communications and BA Honors Development Studies at the University of Johannesburg, currently studying LLB at the University of South Africa. She is employed as a member engagement specialist at PPS Insurance Company. She's previously also been a business unit manager and marketing specialist at PPS. She is supported by Ms. Khomotso Letlape with BA in Economic Management Sciences at University of South Africa, who is an executive financial planner at PPS also. Okay, I'm going to invite Ms. Incapacity Tole to share her slides and let us know when she's ready to start. Thank you very much.
Thank you, Doc.
Okay.
Good evening.
Yes, I can hear you, Ingebo.
Thank you. Please indicate if the presentation is on the screen.
It's showing. You can go into the slide mode.
Thank you so much. Okay. Okay, today we will be talking primarily about the Labor Relations Schedule 8, Item 10 and 11. Item 10, incapacity, ill health, and injury. Item 11, guidelines in cases of dismissal arising from ill health or injury. And then I have shared case law, and I've recommended a few reads that I think would be of most significance in this topic.
Sorry, Ingebo, if I may,
Yes.
just for a moment.
Yes, Doc.
Yes, to make this practical, I just wanted to introduce our patient that will be managing tonight so that
All right.
everybody can be able to apply knowledge and information learned today. Just a moment, if you don't mind. Our patient is Mr. Johan Hendricks, a 54-year-old production manager who's also an engineer by qualification at ABHE Pty Limited. He is a shift worker who is typically on standby due to high demands of his occupation. He is divorced and lives with his new partner. He has 4 children who are aged 24, 21, 16, and 14 that he looks after. He's been a hypertensive for 14 years, an insulin-dependent diabetes mellitus patient since 2014. He's on treatment for both. Unfortunately, they are both poorly controlled. He has no prior complications. He was admitted previously over the past 5 years with high sick leave utilization and currently has 22 days left as at the 1st of March 2024. He presented at local private hospital on the 2nd of March in 2024 with weakness of his right side and inability to speak. He was subsequently diagnosed with a massive stroke with hemiplegia and aphasia and admitted in ICU for about 6 weeks. And then eventually was discharged during April for local rehabilitation center where he currently is. He's got no sick leave left as we speak. He's unable to work yet, and he visits us today with his partner on a wheelchair, unable to walk and speak. Please go ahead. Thank you.
Thank you, Doc. Maybe just for my own benefit, could I ask whether we know for how long he'll be in this condition? Okay, I can proceed.
Yes.
Am I audible?
I didn't realize I was muted.
Yes.
We don't know how long he will stay in this condition for. However, he's unable to work at this moment, and that's ever since March. So we are seeing him just for follow-up because he's been away for too long and he no longer has sick leave. But let's assume he's unlikely to recover. Please
All
go
right.
ahead.
Yes, in terms of item 10, the employer has to first determine whether the incapacity is temporary or permanent. And this is the process for temporary incapacity or injury. The requirement in terms of the LRA is that the employer must do an extensive investigation of the incapacity or injury. They must consider the possibility of how long the employee will be absent. Hence my question. Okay, I just need to. They need to then explore all possible alternatives short of dismissal. In these considerations as alternatives, what is relevant is the nature of the job, the period of the absence, the seriousness of the illness or injury, the possibility of securing a temporary replacement. Our case in point seems to be falling more on this aspect, which is the process of how you manage a permanent incapacity. The employer then needs to explore the possibility of alternative employment. The employer has an obligation, if there's no alternative employment, they need to look at adapting the duties or work circumstances of the employee to accommodate the employee's disability. The right, when they go in terms of a incapacity hearing, where the two has failed, when they go into this hearing, they have to afford the employee a right to state their case, as well as affording them the right to be assisted by a union representative or a fellow employee. While we have the process continuing, the degree of the incapacity is relevant to any termination or dismissal for incapacity. The cause of the incapacity may also be relevant. An example, alcoholism or substance abuse, or whether the employee was injured at the workplace itself. And then the alternatives that they could consider as an employer is treatment for rehabilitation, is treatment or rehabilitations. These will be appropriate steps to be taken. Particular consideration should be given to employees who are injured at the work or incapacitated by work-related illness. So that is important. It is a heavier burden on the employer when the employee is injured at work or during work-related activities. Okay, when you look at item 11, it wants to emphasize that when you want to prove whether a termination for incapacity was fair or not, so this is relevant to commissioners or chairpersons of these inquiries, or even a line manager when they're looking into taking an employee through this process, is that when observing the principles of natural justice, you just don't terminate services without having explored this. So it's a heavy burden on the employer to go through it. It's whether the employee is capable of performing the work. That is what the commissioner or chairperson of an inquiry would look at. If the employee is not capable, the extent to which the employee is not capable to perform the work, the extent to which the employee's work circumstances might be adapted to accommodate the disability, or where this is not possible, the extent to which the employee's duties might be adapted, the availability of any suitable work. So this is important to consider when you're going to be looking at whether or not the employer terminated the employee fairly and procedurally so. I then went in, I thought a case of interest would be the Paraxel International Pty Limited versus Chakani and others. In this case, the employee had been injured and subsequently been off from work for 9 months, during which the employee had submitted medical certificates indicating various reasons for their absence. I think what is important here is the medical certificates were many. However, there was no medical report. As I go through the case, you'll understand what I'm saying here. In this case, the court had relied, this case was at the Labor Appeal Court, the LAC. In this case, the court had relied on the case of Kivitskroon Country Estate Pty Limited versus Muledi and others, which held in paragraph 31 that an employer is not expected to tolerate an employee's prolonged absence from work for incapacity due to ill health. And it may, if it be fair, so there must be a full procedure in terms of Schedule 8 of the LRA, item 10 and 11. Having considered all those facts, if it be fair in the circumstances, exercise an election to end the employment relationship. Frustrating the inquiry process through a lack of providing a detailed medical report or opinion. This is where legal practitioners must come in to assist the employees. They will go back to the legal practitioner and ask for this report. In my experience, what I've experienced is that most of the time employees come back and says the doctor is not available, the doctor is not giving reports, and this unfortunately will prejudice the employee. So we continue with the case law. The court in Paraxel's case held in paragraph 18 that the fact remained that in failing to provide a report as to reasons for her absence and an assessment as to when her recovery will be expected. Basically, they're saying a prognosis and a diagnosis was important. The employee frustrated a proper consideration as to the basis for her extended absence. So because the report was not there, the employer could not be clarified or even satisfied. So in Paraxel International, we continue the case. The court in Para 20 went on to hold that it is self-evident that whether an employee is willing and able to work, and when she may be in a position to do so, are material considerations on an employee's incapacity, whether she has been absent from work for an unreasonably long period of time and whether alternatives to dismissal exist. The employee's extended absence from work was not explained by way of a properly detailed medical report. The different medical certificates provided to the employer did not explain why her extended absence from work had been necessary or why her continued absence was justified. On her own version, the employee was unable to return to work and was unable to indicate when she may be able to do so. In conclusion, the court concluded that the employer was not required to hold an employee's position open indefinitely when the employee had failed to provide any clear basis as to the reason for and anticipated extent of the employee's continued absence. Thank you. That is the presentation. And then I'm just indicating here that the most important reads to consider for this. I relied on the LRA, as I've indicated, and then in my research, I went and I realized that there was a government gazette for the mining sector. It is an important guide as well. And when you're dealing with the public service, you will then have to consider the public service leave determination. And any employer's policies in terms of incapacity are very important to consider when satisfying a process of incapacity, whether it's for injury or for ill health. Thank you.
Thank you, Ingabo. Colleagues, LRA, by the way, is the Labor Relations Act. And if you had attended our session in May, I think, on the legal framework of occupational health, you'll realize that we intentionally missed it out because we were planning to handle it today, or at least aspects of it. Thank you very much, Ms. Ingabo. And I just have a couple of questions, and I'm hoping that our colleagues also have questions that can be dealt with at the end. So for this session, and because we have a couple of panelists that still have to share their knowledge with us, I'm just going to ask you a few questions and then we move on to the next panelist. The first question is, when the employee has been absent for a long time, when do you start anticipating or considering that this might end up becoming an incapacity case?
Doc, this is where I say it is very important for a medical report to outline this. Remember, the employer is not a medical expert. It is
Yes.
important for the treating doctor to indicate to the employer that unfortunately the employee is in this situation, even indicate that the recovery duration is not known, but give an estimate, so that we know which aspects then do we then explore to assist the employee, not just run into incapacity hearing, you know. So for us, that is important. I'm going to hasten to say when medical practitioners write their reports, they must have this in mind, that it is important that the employer knows when will they, or even not, even if it's not definite, but a estimate when will the employee come back, so that they also can have those arrangements in terms of getting a temporary worker. And also maybe just to add in the question, it's playing in my head right now, where you said the employee does not have leave, now they are still at home. In some employers' policies, there's this incapacity when it kicks in. When your leave days are depleted, you then find yourself probably having to go the half pay aspect. When they give you an extended number of days, when you exhaust that as well, you will find yourself now, unfortunately, being on unpaid leave. So some employers also have the insurances where you can get maybe, let's say, temporarily booked off or boarded off, and then you get a certain percentage of your salary. So these things are important in that when you apply for such processes, reports are important because the insurers have their own risk assessment, or should I say health risk managers, that are looking at these cases on an individual basis. But the most important thing is that the medical reports are there and they make sense to the other professional who will be like a second opinion. Okay.
All right, thank you very much. And that's very informative. The second question is, what can be done to ensure that the case is managed timelessly to minimize financial implications to the employee?
Yes. The minute the employee is incapacitated, it is important to inform the employer. I know there are situations where the employee themselves cannot contact the employer, but it is allowed in most companies to bring forward a report or a sick note by a next of kin or a dependent. So inform the employer in time so that they know where you are at. So that where I work right now, the process is if they see that you booked off for more than 14 days, they flag with the insurer already, they start the process of application. And once the process of application is started afresh whilst you're still earning, there's an assessment that is being done, then they can then place you on the temporary boarding so that you can get that percentage that I spoke about of the salary. So you see, at that time, it is not going to affect them so hard in terms of where they would now have to go into the policy that says 50% of your salary. After the extra days are depleted, then you are on no pay at all. So that is my advice. I would advise that communicate promptly with your employer, give them feedback, give them the reports, do fill in the application forms if they say you should. Do not sit until you are out of hospital. You know, just ask somebody to assist you so that these processes can run and you are not deprived in the pocket. I hope that helps, Doc.
Yes, thank you very much. And what is the role that family members can play to make sure that the employer is kept updated in terms of the employee's whereabouts? And I'm specifically mentioning to the point where you said sometimes the employee himself or herself is not well enough to communicate with the employer. So what role can the family members play in this regard?
Like I said, Doc, it is important for the family member or the next of kin to go to the employer, inform the employer of the circumstances of the employee, and that is beyond their control, so that the employer can advise accordingly. They will definitely give them the relevant forms to fill and guide them on what is expected and how to bring. Even the timelines are important. When to bring these forms back, what is required, so that the employer can start processing the claim.
Thank you. This one is straightforward. When do you stop paying the employee?
Okay, like I said, it depends on where you are in terms of your leave days. With my current employer, we have leave days, sick leave days that are beyond what the basic conditions is prescribing. So once the employee has exhausted those number of days, even my former employer, UniZulu, had 120 days. UJ currently has 86 days. When that is exhausted, the HR person would then apply for an additional days. However, the additional comes with the half pay. I always encourage the incapacity route for a claim with the insurer as compared to the policy, because with the insurer, what I'm aware of is you can get 85% of your salary, alternatively 75%. And for me, that is placing the employee in a better position. Although most employees are averse, or should I say are very resistant for that, because they feel it is less money. But because I have experience and I see where it's going to go, it's going to go to half. Instead of 75 and 85, you will then get 50%. So you are worse off than when you could have explored the temporary incapacity through the insurer route. So some employers, let me talk about pillar. In the public service where there's pillar, and when it is well managed, when the health risk manager has finished assessing your case in about 2 or 3 months, because when you do go on to the pillar process, they do tell you it is provisionally approved. So when it comes back and the health risk manager has not approved for the HOD to endorse, it is leave without pay. Basically, you would have taken the 3 months, but then they have to come back. You already signed a consent. It means now you owe them 3 months worth of money. And for me, that is a disadvantage. So yeah, they will stop paying the employee when they have exhausted the additional days that they had, or when the health risk manager has recommended that, no, this employee is not that ill, they can go back to work. Unfortunately, that is where it is, Doc.
Okay, thank you. I think you've put your foot in it. What is a pillar process?
It's the same as an incapacity process. It's just in government, they say it's a pillar.
Okay.
They manage incapacity, they manage ill health, injury
Okay.
through it. So yeah.
All right. Before I ask you the last question, I just want to clarify to colleagues who are not so lucky, like yourself, who have 86 days of sick leave. 99% of companies or employers in the country only have 36
For a
leave
3-year
days that
cycle.
only last for 3 years. So meaning if you finish it within the first year, you have 2 years without sick leave. And this would typically get loaded after you have worked at least 26 shifts in your employment. So they only become available once you've worked for 26 days. And it is for 36 days, like I have said. But because there are generous employers like yourself and UniZulu, you do get employers that actually have more than what the law prescribes. And I'm hoping we don't have employers that have less
No,
than
no,
what the
no.
law prescribes.
That would not be legal in South Africa to have less.
Exactly. Anything that contravenes the law is basically illegal. All right. Lastly, what would lead to you deciding that this employee is no longer returning to work from your perspective as an HR practitioner? When do you decide that I think this one is not make sure, is not coming back?
I do not have that prerogative, Doc. We rely on you as professionals to tell us that. I do not have that prerogative. But however, like I'm saying, you see, employer now comes and says, Ingabo, case law says, and we have to rely on it. That's why, for me, I will just ask with humility that medical practitioners assist employees because they are vulnerable at that stage, they are ill. If the medical report does not come, I think me and you have handled such a case where medical practitioners don't even want to help an employee with a medical report because
And
they have,
sometimes charging exorbitant amounts for this report. Yeah.
for this report, you know. So that is where I'm going to plead to say, can we give a concise, comprehensive report so that it can motivate for the employee? Because what we've realized is most environments would say, no, we cannot reasonably accommodate because our type of work, like the LRA is saying, you know, you need to consider the job, the tasks, and all of that of the employee, also consider alternative work. So most environments don't want to go there. It looks like nobody wants a sick person because I know there's also case law that says it is kind of unfair on others if they have to carry the weight of the one that is ill. You know, it does sound inhumane, but there's also that aspect that the employer is trying to avoid. And for most employers, it's about productivity, unfortunately.
Okay.
Yeah.
All right. Thank you. And I think this highlights the part where you now decide that, you know what, this person has been away from work for so long and I don't know what's happening with her. I am now referring this person to the clinic. And in the clinic, that's where you find Sister Margaret, always willing to assist, always willing to face the challenges. And again, I think I need to add that the process of incapacity, from the professional point of view, it usually starts with you, the HR practitioner, and also ends with yourself, because you are the one that identifies that the person has not been coming to work, refer the patient to wherever he needs to be referred to, managed. Eventually, the patient comes to you to conclude their employment or to accommodate or to adjust the workplace environment or the working conditions. Sometimes, which is not really common in our country, to retrain the employee. And one day we'll have a full session on retraining employees, because we tend to just dump in the dustbin whenever we can't use people anymore. But for some people, they really do have abilities to, or mileage to maybe consider something else. And then at this point, I would like to introduce Sister Margaret to go through her session with us to tell us what happens now when she receives Mr. Hendricks, who is very much obviously not ready to report to duty, but needs to be assisted somehow and probably even deserves some kind of income because he has responsibilities as we have outlined. Sister Margaret, may you please unmute when you are ready, and then we'll tackle your session when you are ready. Thank you very much, Ingabo. Please stay behind for questions at the end. I'm sure our colleagues are dying to ask you questions that I couldn't ask you. Thank you. Sister Margaret, are we ready?
Yes, doctor.
Thank you. Please
Thank you,
go
Doc.
ahead. I'll
Good
be
evening,
advancing your
everybody.
slides from my side.
Thank you, Doc. I'm ready.
All right, please go ahead.
Okay. Yeah, the first thing we need to do after receiving a referral from HR or line manager, we need to determine the reason for referral. But in this case, we know the reason for the referral. So we need to explain to the client why they are here. And because sometimes, you know, if they don't understand, you don't really get cooperation from them. So the first thing is to have book an appointment for a pre-assessment prior to booking them with Dr. Mkhwanazi. And that will also help for you to build like a rapport with the client, with the patient, sorry, or the employee, because, you know, sometimes if they are confused and they won't cooperate. So that's why it's important to first explain the reason why they are in the clinic. And during the first assessment, like Ms. Ingeborg has explained, the importance of getting a detailed report from the treating doctor prior to booking an appointment with the doctor, with the OMP, because it's pointless to book an appointment with the OMP when the OMP won't have any report to assess the employee on. So it just makes, you know, the process flow easy. And after the pre-assessment, you would then get the employee to obtain the medical report. Like, again, as indicated, sometimes it is a challenge for us OHNPs to get the report. So in that case, then you would ask the OMP. So in our case, our OMP would sometimes I would ask the OMP to write the letter requesting it. But if it's like in the case where the employee has contact details of the treating doctor, I would take an email address and then send an email stating what exactly we need in the report, because the medical report from the doctor must actually indicate the employee's ability to do their job or part of the job, and to also give prognosis in terms of the period involved. So as to, advise also in the report, so that the employer can, have ways of helping the employee to cope with his condition. And that's where the accommodation will fit in. Okay, next doc. Yeah, so after obtaining the medical reports, you will only then make an appointment with the OMP. So then we will assess the employee. The doctor will make recommendations, which will be shared with human capital management, the relevant business partner, line manager, and we usually have a certificate of fitness that is issued with each consultation. That must also be shared with HR and the line manager, so that they know what doctor has recommended, and if the person is unfit to work, for how long. And then we also, during that assessment, we book a follow-up appointment, and the employee will leave our clinic being aware of their follow-up appointment. Next one, doc. Feedback is very important. In our case at UJ, we have a incapacity management forum, which comprises of a representative from employee relations, of which Ms. Ingeborg is part of, employee wellness, human capital management business partners from different environments, and a representative from the benefits office. So after each, like we've got a designated date every month where our OMP assesses these cases, and then we have incapacity register, which we discuss during our incapacity management forum meetings. So that actually helps us to, be updated. We are on the same page with benefits and HR in terms of our incapacity cases. So that actually helps a lot. So feedback is very important. And the line managers and supervisors must also be updated in terms of the process of cases, how far we are and for how long employees are going to be away from work. Okay, the case that doctor has presented, in that case, we need to have regular follow-ups with the employees. Let's say, like, the person might need to be referred to OT or for functional capacity evaluation, or maybe for psychological support. You would also refer the employee with the wife to an EAP. I sometimes, instead of sharing the information with them, because sometimes they don't get to, contact the employees, the EAP, I would on their behalf make a call and then get them to get sessions, at least if they can get the first session of counseling, and they will then get follow-up appointments from the counselor who will be dealing with them. So, and even if the employee hasn't been reporting for work because they are not well, you need to be the person who, contact them to find out, to check on the progress, and then give updates to HR, benefits, and the line manager. Next one, Doc. Yeah, I've already touched on the referrals because depending on the nature of the condition of the employee, if doctor needs you to maybe book an appointment for functional capacity evaluation, that is also our responsibility to do so, and also give feedback in terms of the dates that you have received for the bookings. So there are some cases where you are unable to get hold of the clients, like Ms. Ingeborg has indicated. I would sometimes do house calls, as long as I have sometimes the next of kin that they have provided us with is not available, or the number doesn't work. So just to find out whether the employee is okay, or if you can't get a hold of them, then I would do house calls. I would go to the house to check and see if they are okay, and come back and give feedback to HR and the line manager. Yeah, Doc.
Say Mark, I need more. Thank you, Sister Margaret. Psychological support, I think you have covered that.
Yeah, psychological support is also very important. I have covered that, Doc. Thanks, Doc.
All right. Sister Margaret, you said something about house calls, and I think that's going beyond the line of duty. Yes, and thank you very much for a simple yet very detailed and informative presentation. The role of the OMP in this regard, you are more like a conductor of a choir. You coordinate what needs to happen for the benefit of this employee. Remember, you might be a doctor, but you are not the treating doctor, and you might not have certain information about this employee. And then in this regard, this is the point where you communicate with the treating doctors, sometimes writing letters. From time to time, the employer would request you, can't you call his doctor from one doctor to another and find out when is he coming back? You know, sometimes you get such requests, but I would say it's easier to have written communication that you'll be able to refer to, and for evidence purposes also, because like Ms. Ingebo has indicated, this might actually end up in court, and anything that you have done or said or heard becomes evidence. So your role is to originally assess the employee, clinical examination as a doctor, where you need to get clarity on the severity of their symptoms. And then you are able to refer to certain medical practitioners or certain services that you feel are necessary for the patient. But I want to highlight the need for the treating doctor's reports, because remember, this person started treating this patient about a year or two earlier. They have all the history, and you might be seeing the patient for the first time. And sometimes the employer might pressurize you into becoming the treating doctor, but that is not really fair because you don't know the patient enough. So always make sure that your role is very clear, and that is you are the conductor of the choir, you're not the singer yourself. And most of the times you will communicate with the treating doctors. Sometimes you'll get attitude. Sometimes they will tell you the person is still fit to come back to work. And this is what happens most of the times. These doctors will tell you, and most of them are GPs, and they don't understand the background of the working environment or what is necessary for this person to be fit to work. So sometimes you'll get reports that say, this person is fit to work, let him work. And then you have to disagree with the doctor, and now there is some tension between the two of you, because patients will always run back to their doctors and say, he said he doesn't agree with you. And it always appears as if you are undermining the doctor, unfortunately. So assessment outcomes that you get from this kind of examinations or sessions with patients, you might feel, in best case scenario, you might feel the patient is fit to return to work. And they can either return to work in full capacity or on a limited capacity. This is where we talk about reasonable accommodation as dictated by the law, but most companies, as you know, are not familiar with that concept of reasonable accommodation. It's either you are fit or you are not, but unfortunately there is a gray zone in between. So reasonable accommodation will mean usually the supervisor, sometimes assisted by the clinic, will identify what it is that the patient is still able to contribute and assign duties based on the patient's capabilities. And by the way, this also happens if you have disabled patients or disabled employees. Remember, they might not be fully capable of performing 100% of the tasks, but you might realize that this employee is very good with the phone, very good with interacting with clients, and if he's sitting nicely on his wheelchair behind the desk, they can still be able to work. So you either allow them back at work based on ability to do so fully or partially, or what we call redeployment. Redeployment is when you now decide, okay, Mr. Hendricks might have been a very good engineer, but now he can be a very good executive attending meetings because he's no longer able to do this. So we can still use him because because of his experience and expertise in our company. And then sometimes, unfortunately, it happens that you are not able to accommodate the employee in any way. And this is where we talk about temporary incapacity for employees that are not able to work, but they still have potential of recovery at some point while you're following them up, or permanent incapacity where this employee will never be able to recover, or at least it's unlikely that he will recover. So I just wanted to outline and summarize Sister Margaret's nice and informative presentation from the doctor's perspective. And like with the previous session, I have a couple of questions and then we move on to the next session. Sister Margaret, what kind of information or documents are required during the referral to make the whole process as smooth as possible?
Thank you, Doc. Obviously, the first one will be the detailed medical report. Sometimes it also helps to have men job specs, so that when the OMP gives recommendations, it must be reasonable. Because sometimes we get instances where the supervisor or line manager will say, like the case we had where a person, like the employee will tell us that his job allows him to work remotely. And then you get a different story from the line manager or the supervisor will say, no. 10% of the employees, job description allows him to work remotely. So then it's like, so it helps to have a man job spec. And then the other thing is like a consent form, like for cases where we need to refer the employee for functional capacity evaluation or any other assessments. So we are going to need a consent form from the employee. And I think those are the most important documents that we're going to need for referral to speed up the process.
All right. Thank you very much, Sister Margaret. Would you recommend for HR to just conclude the case without the clinic in the workplace that has a clinic such as where you're employed? Would you go like, yeah, I trust you, go ahead?
No. I think the input from the clinic and from the medical team is very important because I mean, let's say for instance, if the case where they need a medical report, they won't be able to get that. The doctor won't provide them with a medical report because they don't have any medical background.
Yes.
So so that is not possible, Doc.
And as a nurse, is there a role that you can play should the employee return to work and be accommodated? How would you make this as much comfortable as possible for the employee?
Reassurance and doing regular site visits and to see and make sure the employee copes, and because sometimes they are moved to a different environment altogether. So just to be there for support and to just reassure them.
All right. Thank you very much, Sister Margaret. To outline the process, colleagues, in this case, we have a patient that's been referred to us, Mr. Hendricks. We've managed him, we've obtained all the reports, and like I've mentioned, he's come to see us on a wheelchair, unable to speak, one side of his body not working. So it is clear that Mr. Hendricks is unable to work at this stage. But however, The assessments that we make are usually qualitative, meaning it's a yes or no kind of situation. We do have colleagues that are capable of making quantitative assessments to be able to say, looking at the job spec, this he can do, that he cannot do, that he can do, this maybe, or let's wait a bit with that. And that colleague is an occupational therapist who does what we call functional capacity evaluation. At this point, I'll invite our colleague, Nicole Debray, to brief us on functional work capacity and let us know exactly what it is about and how this wonderful process can be utilized to make the process easy. Nicole, are you there?
I am here. Can you hear me?
Yes, thank you. We are full today, so I was worried that you would get cut off, but I'm glad you're still here.
No, I'm here.
Go
Can you
ahead
see
and share.
my slides? Okay, can you see my slides?
I've stopped sharing. Yes, I can see us.
Okay. All right, perfect. So good evening, everybody. I'm Nicole Debray. I'm an occupational therapist. I started off in psychiatry, which gives me a nice background, but I've moved into the FCE medico-legal fields. So I'm going to start off by going through what we look at when we do an FCE and sort of go through the thought process that an OT generally takes through an FCE. So in FCE, I sort of group it into two main sort of assessments. We've got the physical assessments, and then we've got a psychosocial assessment. The physical assessment looks at all physical components, and I'll go through that in a little bit more detail now. And then we've got the cognitive assessment, and then also the mood, perceptual, social skills assessment. An FCE always starts with a very in-depth interview. We look at individual job tasks that a person might do. A cashier doing one work is very different to another cashier, and their job tasks are very different. So we look at each job tasks and we break that down into the skills that are required. We get a full medical history and also their current complaints. We then do the actual assessment, so the physical and the psychosocial assessments. And then at the end, we will then get collateral information from an employer, previous employer, or family member as is needed. So the physical assessment, I think this is the one that most people are aware of. We use generally, an OT will use a standardized protocol. Generally, it is either WorkWell certified or ErgoSign. So I am WorkWell certified. So all the discussion about the physical assessments, I will be discussing the WorkWell certification. The testing considers load handling capacity. So that is basically your ability to lift and carry or transfer any weight. And the position tolerance includes your ability to sit, stand, walk, climb stairs, bend forward, work with your hands elevated over your head, crouching, kneeling, stair climbing, and ladder climbing. So that all looks at the position tolerance. So part of the US Labor Department norms, we consider as part of the standardized assessments, we break down a person's ability to perform physical tasks as well as the actual work tasks as either sedentary, light, medium, heavy, or very heavy. And we consider the work tasks in a proportion of the day. So are you required to stand for X amount of time? Are you required to walk for X amount of time? And then we break it into rarely, which is 0 to 5%. I see on the table it's a little bit different. Rarely is 0 to 5% of their work day. So that is 8 hours, 10 hours, 12 hours, whatever they are working. So occasionally is then 6 to 33%, frequently 34 to 66, and constantly 66 to 100% of their workday. So we need to know exactly what their workday is. Then we do the physical tests and we break it down. We then look at the cognitive tests. They are standardized, and I specifically use non-standardized tests as well. So the standardized tests, in my opinion, are mostly American-based and are outside of the frame of reference of a South African. So one of the tests I use has an anchor in it. A lot of the South African population, they don't know what an anchor is. So they get marked down on their cognitive functioning, but it's not something that is very familiar to the South African population. Other tests also, the wording is very American. So I like to use non-standardized assessments. So I give them an assessment tasks, and I use clinical reasoning and observation then to make a determination on their cognitive skills and task performance. So I use both. I use standardized and non-standardized assessments in an FCE, specifically if there is a question around the person's cognitive functioning. So for our case study, as an engineer and as a production manager, there would be quite a big component of his work that is very cognitively based. So we would need to cover all our bases on the cognitive testing. We then look at mood and a social skills assessment. This is generally done through observation and during the interview, and also gaining collateral information. This is generally very subjective. And a lot of the OTs that work in the industry, they rely very heavily on standardized questionnaires. I'm not a big fan. Once again, they're American-based. They're not within our population. We need to take our population into account and everything that comes with being a South African. And I find the standardized questionnaires to be quite biased. So I do use standardized questionnaires, but I like to back it up with clinical observation, interview, and collateral information. So you're closing off the triangle per se of getting all your information from different sources. So once testing has been concluded and we've done all our collateral information and we've got all our information, we are then able to see, does the person match their physical abilities to their work tasks? So from the interview, we've gotten all the information. They're sitting occasionally, they're walking really, we've got all of that, and we can then match what the abilities are to what we're trying to achieve. The next slide will show that in a bit more detail. From there, we can then determine, are they suited to their work or are they not suited to their work? And if they're not suited, can we possibly make accommodations to the areas that they are not suited? Just a note that for the feasibility of an accommodation, collateral information from the employer or the company might need to be obtained just to see what is realistic. And I've got a few slides on that just so that we can all be clear on that, because I think that's very important. Right, so in my report, I put a table like this. So we can see the physical requirements as per Workwell that I explained before. We've got your position tolerance testing and you've got your material handling towards the bottom. The next column over is the frequency obtained during testing. So in our production manager position as part of our case study, I have guesstimated he would be able to sit occasionally. I expect there would be some discomfort, some shifting because of the hemiplegia, and he might be a little bit of an angle, so I've marked that as occasionally. So he's able to do that, or he's able to sit frequently, but there might be some limitations. He's able to stand occasionally, so between between 6 and 33% of his day. I estimated that he's unable to work with his hands overhead because of the hemiplegia, and so on and so on. So we've basically determined from a physical perspective that he's not suited to walking, because I'd expect as a production manager, he's walking around quite a bit in the warehouse. But his walking is impaired. I didn't know he was in a wheelchair, so that would actually be unable. So he would be not a job match there. He would not be a job match for any lifting or carrying. Now, this does not take into account the fact that he most likely is unable to do any bilateral hand tasks because of the hemiplegia. So he's most likely unable to type. He's most likely unable to write, which is generally essential for work as a manager. In addition to this, he has aphasia. So he's unable to communicate with staff. He cannot give instructions. He cannot understand instructions given to him to a large degree because of the aphasia. And he wouldn't be able to communicate in written language, which once again is very critical for anybody in a managerial position. In addition to this, generally, when we see such a pronounced, profound stroke or CVA, we generally see some sort of visual perception impairments as well, which I would then also explore during an FCE. And when we consider that he was an engineer and a production manager within an engineering company, it is likely that he would be working with some sort of machinery or tools. Now, if you've got visual perceptual impairment, most likely some sort of spatial perception impairment, the safety of working in a manufacturing or engineering workshop might be compromised. So once again, we need to get a full indication of what his job specs are. So when considering the fine motor impairment, the aphasia, and the most likely visual perceptual impairments, I would then recommend that he's not suited to his employment and he cannot be accommodated, because those aspects are unlikely to improve and we cannot accommodate him within his work to be able to sort of mitigate those impairments. If hypothetically he only had his lower limbs affected, so for example, his lower limbs were affected, but his upper limbs were not affected, and his speech, his understanding, the aphasia wasn't an issue, and his perception was fine, then I would say that maybe we could accommodate him in his position, because we can accommodate for the walking, we can accommodate for the lifting. In his position, it is most likely that he can then direct somebody else to be able to lift heavy items, and he can be more office bound and ask people to come to him, or ask a subordinate to oversee the running of the production floor, or the engineering workshop. So there we may be able to accommodate him if it was purely a lower limb limitation and not the upper limbs perceptual and aphasia. I hope that makes sense. Okay. Now, we're moving away from our case study at the moment, because we've now determined that he cannot be accommodated in his position. But for example, if he was a partial job match and he needs accommodation, we need to be very, very careful about what accommodations we recommend. And we need to bear a few things in mind. Employers may be reluctant to accommodate an employee, as it's easier to replace the employee. It is easier with the unemployment rate as it is, especially with your unskilled and semi-skilled employees. We really need to be very careful about what accommodations we recommend. Another thing to keep in mind is, even if you do accommodate a person, very often the pain might still be present. And if pain is present, it affects productivity and their motivation to work. So although pain in essence is not a functional limitation, a lot of people work despite the pain, there are consequences to the pain. So we kind of need to manage pain as best we can to preserve as much productivity as we can in the person. The less productive, or the more we need to accommodate a person, the more likely that their remuneration will be affected, or their contract will not be renewed. They won't get a promotion, their career progression sort of stalls or stops. So we need to keep that in mind. If a person continues to work in a higher position than what they are really suited for. So they're doing work of a greater nature than what they are actually suited for. There are consequences to that. So if they have degeneration of a joint, so if they have a hip osteoarthritis, knee osteoarthritis, whatever the case may be, that will be hastened and they will be more incapacitated faster by carrying on in that position. Once again, pain, all right, we always need to come back to pain will affect their work performance. They are at greater risk of further injury or workplace injury if they continue to work in a higher position than what they are suited for. And there is a pronounced psychological effect on not meeting or not being able to work as they know that they should be able to. And that affects their motivation and their will and their mood and all of those kind of things as well. So we all know, I'm sure, what reasonable accommodations are and the definition and all of that. So I've left out the definition of reasonable accommodation. But from an OT's perspective, the following is what we kind of consider when we talk about reasonable accommodation. The first one is assistive devices. So if we have a cashier who is not regarded as suited to constant standing, we would provide a high chair so that she can sit down while she works and she can carry on working. Or we provide a sit-stand desk or whatever, my mind's going blank now, but an assistive device to assist them to make them suited for their current position. We can then look at adjustments to the actual work tasks to limit a certain thing. So if they can't lift and carry, we might want to change the role of the person to a cashier instead of a merchandiser. So they're no longer lifting stock and packing it onto the shelves, but they are now just working as a cashier. So there's no lifting and carrying involved. Then we look at the adjustments to the work hours or including rest periods during those work hours. And this is generally to manage pain symptoms or fatigue levels. So I've seen a lot of cases lately with your post-viral fatigue and things like that, or your fibromyalgia with your chronic pain. So we adjust the work hours to maybe miss traffic, or we adjust work hours that they work for 4 hours, rest for half an hour, and then continue to work. So it's just adjusting work hours to manage whatever symptoms they're presenting with. Lately, we've been recommending quite a bit of hybrid work, and that helps with, once again, pain management, fatigue management, mood management. So if they've got mood symptoms, it might help with anxiety if they've got anxiety about traveling or PTSD or anything like that. And then retraining for another position. So it was brought up earlier. It is not recommended very often because it really is very dependent and most often applies to sedentary to light work or admin related work. And this is greatly impacted on by the person's education level. So before they were injured or ill, their education level, their past employment history, and their cognitive ability. So for our case study, retraining for another position might not be feasible because his cognitive faculties have been impaired. Likely that we'd be able to retrain him into another position where he would be suited. Okay, the more accommodations that are needed, the less the employer is likely to meet these accommodations, and it goes back to the actual definition of a reasonable accommodation, that it must not be undue hardship on the employer. So we need to be very, very realistic about what is reasonable, and we need to consider what is reasonable for the client and what is reasonable for the employer. unrealistic accommodations that are recommended may lead to the client losing their job unfairly or unrealistically. So every accommodation that is put on paper really needs to be thought through, and very often the employer needs to be contacted and said, is this a reasonable accommodation? Like, can we provide a chair for the person to sit on, or is this unrealistic for you? So it's just something that needs to be kept in mind when making a reasonable accommodation. Is you need to consider what is realistic for the employer, but also what is realistic for the client as well. So that just needs to be kept in mind. I've added in sympathetic employment because it seems it's coming up more and more these days. Is a lot of people are recommending or saying that it's sympathetic employment. Now, sympathetic employment is if a person is actually unsuited to the employment, but they are kept on in the position due to sympathy. Now, the importance of this is that if the person loses that employment, they would unlikely be able to get employment again. And if the employer then loses their sympathy, they will then lose their position quite quickly. On top of this is, I've noticed in a lot of the expert reports that I've been getting lately, is a lot of other experts have been, or other health professionals have been recommending sheltered employment, especially clinical psychologists. I don't know why, but they're recommending sheltered employment these days. Now, sheltered employment is seen as a therapeutic tool where somebody can go to a facility and engage in a productive, worthwhile activity, but it is not for remuneration, and sheltered employment should not be seen as employment in the open labor market at all. So if you see sheltered employment being recommended, it is not employment as in the fact that you're being remunerated for it. Okay, I just wanted to add those two things in. I think that there's some confusion around that. Okay, that is the end of my presentation. So if there are any questions for me.
Thank you, Nicole. Of course, there are questions. I think we've just learned a whole lot of things that some of us have never heard before, like sympathetic employment. But thank you very much for this informative session. And I think it's very important because most of the times we try and manage these patients ourselves and end up having our fingers beaten when we have to maybe witness in court or justify our decisions, especially when we have not considered important tools such as functional capacity evaluation. The first question we have is what kind of information or documents would you require to be able to effectively assess this patient for ability to work?
I need a clear diagnosis and an estimated prognosis from you. So from a doctor, I require a diagnosis and an estimated prognosis. X-ray reports, so if we're going towards any sort of degeneration of a joint, or if there was a fracture of, I don't know, a femur, are we expecting there to be degeneration in the hip or the knee or whatever? So X-ray reports are generally helpful because that gives me an indication of where this person is going long term. So then I can make an estimation of, will they be suited to their work in the future? I always say to clients, what I'm doing during the assessment is like I'm taking a photograph of their functional ability as they stand in front of me. But all medical information that I get from the referrer or whoever sort of helps me put the picture around it. So that gives me the before and the after so that I can get the whole picture and not just the photograph that's in front of me. So a clear diagnosis, any sort of X-ray, MRI scans or anything like that. I don't need the actual scan, but the report that goes with it so that I can start building the picture around the person. Obviously then contact details, but I generally get that from the client anyway for the employer or family members should I need collateral information.
Thank you, Nicole. And perhaps a very important question is, how long does this process usually take? Because from experience, I could say most employers would pressurize us to getting the report as soon as possible, like tomorrow or next week, because we want to know what's happening with this person so that we can hire somebody in their position or so that we can conclude the case. So let's say I send the patient to you, taking into consideration that the appointment might not be immediate. How long does it take between when you receive the patient, do your assessments, and when I finally have the report that says, yes, you can fire this person?
So my assessments, you phone me for a request, depends on my availability. Generally, I'd make a plan if it's urgent, okay? The assessment, it depends on how much needs to be assessed. So the assessment is generally between 2 to 3 hours for a straight physical assessment. If you are then including the cognitive assessments or the psychosocial assessments, it can go up to 4 hours. The report, I do quite an in-depth report. It can take up to 10 hours for me to write a report. So I generally tell people it takes me 2 weeks to do the report just so that I can manage my time. I don't like to be pressured to write a report because I need my brain to work optimally to consider everything to put it in the report. Obviously, if there's time constraints, I would obviously prioritize it. So generally, I would say 2 weeks to get a report. And the assessment would then take generally between 2 and 4 hours.
And if I may ask, if you are able to share, why is it so expensive?
Because it takes so long.
Okay.
So, I mean, I charge medical aid rates, and I basically estimate the time that would take it and then multiply it.
Okay.
If I'm looking at 2 to 4 hours for an assessment and then an additional 10 hours for the report, you're looking at about 12 to 14 hours for one matter. And that's why. Because there's a lot that needs to be considered. There's a lot that needs to go into it. It's not a basic, quick thing.
Thank you. That makes sense. How would performing the functional capacity evaluation benefit both the patient and the employer? And I promise that's the last question for now.
No, that's fine. Because we look at it so in depth, we get a very good understanding of what the person is required to do within the workplace, and we get a very good indication of what the client can do, and we can match those two very well. So we get a very realistic idea of where we're at. So after a functional capacity evaluation, the employer should be walking away with a concrete, realistic idea of what the person will be able to do now and what they will be able to do in the future. They should also have a detailed plan of what steps need to be followed to go forward. So at the end of an FCE, in the recommendations, I would then make, if the person is suited to return to work, we do a return to work plan. So for X amount of days or X amount of weeks, they should be doing X, Y, and Z with whatever accommodation. Then for the next 1 month, 2 months, whatever, they should be doing X, Y, and Z. And then we expect a full return to work in 6 months or whatever the case may be. So we make provision for every eventuality in the FCE. So the employer then knows exactly what's happening. The client or the patient will then also know exactly what's happening and what they can realistically work towards. So it takes out all the question marks on everything, and it just gives clarity on the way forward and everything that needs to follow. What accommodations are needed, when that accommodation should be done, and all of that kind of, the progress that needs to happen. So the return to work plan is part of the FCE recommendations, and that should detail exactly the process that should be followed until successful return to work. Obviously, that might change as the person starts returning to work, or might be accelerated or slowed down, and that's why there's a case management that generally goes with a return to work program, so that we can make accommodations and recommendations as we carry on.
All right, thank you very much. I would like to hold it here for now, and we will have last few questions at the end of the session. Colleagues, usually when we receive a functional capacity evaluation, we now go back to HR or human resources or employee relations, depending on how the position is termed per company, to give feedback and to make final recommendations. Having a functional capacity evaluation is not an excuse for the clinic, meaning the sister and the doctor, not to do their job. We still have to interpret the report to the patient, explain to the patient what the report means and what the implications are. And usually these reports, I'm sure Nicole would agree, they usually come with a small disclaimer that says, if you're going to share this with the patient, please make sure the patient is properly counseled. So meaning the union cannot come and demand a report and then you just badge like that and give it to the union. Usually we arrange a session with the employee, explain exactly what the report means, what the implications are, and explain what you are going to share with the employer. Because remember, the employer needs to know what's happening, and that's where you come in. Your role is to interpret this report in a safe way that does not violate any confidentiality. All those tables that shows that the employee scored 5 instead of 25 and could actually be used against the employee. So when you go back to the employer, you just share recommendations with yours added and your modifications that you would like to add to the recommendations of the occupational therapist. At this point, colleagues, we realize that sometimes these cases are not managed properly. And most of the times we realize that when it's late already, too late to do anything, we realize that these colleagues or these employees are not properly insured. And as a result, this sometimes pressurizes them to try and twist your hand to let them continue working, even when you can literally see that this person cannot cope. So for that reason, we have invited Ms. Rebecca Sekhaulelo and Ms. Khomotso Letlape to give us a bit of background in terms of insurance and benefits that are available for employees while they are working, while everybody is happy, enjoying the salary nicely, and they are not missing work before things go south. So we've managed the part where things have gone south, but now we are rectifying the situation. Sometimes employees need to hear this advice from you, and it's important that you understand the basics of the insurance industry in our country to be able to say, how about you take this policy in case you develop a stroke one day and then you know you are covered. At this point, let us welcome Ms. Rebecca Sekhaulelo and later on Ms. Khomotso Letlape for questions. Rebecca, are you there?
I'm here, Dr. Mkhwanazi. Thank you so much. Do you want me to share my slides or do you have them with you?
I would like you to share them, please. Let me just
Thank you
stop
so
sharing.
much. Oh. Okay.
Ready when you are?
Okay. Can you guys see my slides?
Yes.
Okay. Good evening, ladies and gentlemen. I think Dr. Mkhwanazi, you've introduced it quite well. We sometimes now, as individuals, continue with our day-to-day lives and pray and hope that nothing goes bad. You know, we go to work, we do our day-to-day jobs, and it's sad when we see tragedy strikes and we are faced with the situation of our case study. We're sitting with an individual who's now sitting on a wheelchair and unable to perform their day-to-day duties. And that's where companies such as PPS comes in. I'm just going to elaborate on, firstly start by introducing the concept of the PPS company. So PPS basically stands for the Professional Provident Society. Basically what it is it's an insurance company, but it's only for graduate professionals. So you need to have at least a minimum of a 4-year qualification to join PPS. And we've been doing so, looking after graduate professionals since 1941. And it's been going well due to the fact that we are what we call a mutual company. Mutuality in the sense that we don't have what we call external shareholders. Our members are actually the shareholders of the company. So every year, when we declare our dividends, our members are actually allocated a portion of the shares and the dividends that the company has accumulated over the years. And it's a very beautiful model. And I like the fact that it's exclusively for graduates. So we don't just accept anybody. Like I've mentioned, you need to have at least a minimum of a 4-year qualification. I take it everybody in this webinar would probably qualify for PPS. It's the only company currently in South Africa that operates under the ethos of what we call mutuality, where our members are not just policyholders, they're also shareholders of the company. Okay, you might just ask yourself, what does PPS do? It's a one-stop area. I always say we have everything from your life insurance to your sickness benefit, disability, your health professional indemnity, which is also very important, especially for our professionals like your doctors and your pharmacists. We also offer estate planning. That's a topic for another day, where we actually go in and we educate our guys on the importance of actually protecting your legacy, having a will in place. We also have business assurance for those of you that are currently in private practice. Your car and home insurance. We've got long-term investments as well. So this is just to explain to everybody in the webinar how the profit share works. So basically a profit share, like I've mentioned, is basically a reward that we give to our members for being a part of PPS. It's nothing, you don't pay extra for it. It comes automatically by virtue of you having a product with PPS. If tomorrow you decide to take out a policy with us, automatically you become what we call a shareholder of the company, meaning that every year when we declare dividends, you also get a share. This is money that you accumulate throughout the years as a member of PPS. And at age 60, when you retire, the money actually pays out lump sum tax-free. And if it happens that you do not reach the age of retirement and God forbid you pass away during the course of your life, we do pay out the profit share to your beneficiaries. Or if you decide to say, listen, I don't want to be part of PPS anymore, we do pay out the profit share at cancellation, which is something that we don't encourage because the taxman does want a portion of that money when you cash it out, as compared to when you cash it out during retirement. So as a company, we exist solely to pay claims and for the sake of wealth creation for our members. And our sole purpose is to help our members protect their dreams and grow and secure their financial worth. We've seen a lot of graduate professionals working their whole lives, and it's quite sad how somebody would retire at the age of 60 or 70, and you see them living for another 30 years without a solid income. And that's where PPS came in, and they realized, you know what, we need to bridge the gap between the time a graduate professional graduates to the time they retire. That is a very important time in your life where there is no longer an income coming in. And imagine having paid your insurance premiums for those years that you've been working, and here you are at retirement, your insurance come in and say, listen, we want to reward you for actually being a member with us, regardless of whether you've launched a claim with us or not. So as a financial services provider, we always do what we call holistic insurance, where we start very solely by talking about estate planning for you. Like you can see from the bottom, where the stages start from the bottom, they have to be balanced. You know, we first educate you when you sit down with a financial advisor like your Khomotso, they sit down with you and they do a whole cash flow management process. They look at the risk that you will establish as a graduate professional. How are your investments looking? Are you protected? Do you have a retirement plan in place? And is your estate planning done properly? So I'm going to dive in very nicely and link this presentation back to our first speaker, Miss Ingeborg. She said something very important. She spoke about how the company can make an arrangement for you in terms of getting your salary, but it also depends on the number of sick days that you have available. And she did mention that there are some insurance companies out there that would make an exception or maybe allow you to launch a claim against you being sick. And that's where PPS comes in. Our flagship product that we have at PPS is actually called the PPS Sickness Benefit. It's called as SPPI because of it also incorporates what we call an incapacity benefit. So basically how the sickness benefit works is very different. There is no similar product in South Africa in the insurance market. Some of them call it income protection, they'll call it different names. And the reason why the PPS sickness benefit is very different is because it goes from being sick to incorporating what we call a permanent incapacity. And it doesn't require you to produce any proof of loss of income. So you'll see with the income protection what the rest of the industry is actually offering. In a case where you are sick and you are deemed permanently incapacitated or just sick and being booked off, they will require a proof of loss of income. So meaning that if your employer continues to pay you, they will not process your claim. Your claim is considered invalid. So the nice thing about the PPS one is we do not ask you for proof of loss of income, hence it's called the sickness benefit. What we require is just a declaration from the doctor, your medical practitioner, saying that you have been booked off due to a certain illness and how long are you going to be booked off for. So I'm just going to dive in and talk about the sickness the SPPI, which is the sickness and permanent incapacity benefit. So this benefit actually pays a member on a monthly basis in an event that you are deemed sick or unable to perform your normal duties. And the nice thing about it is after it's from 7 days onwards, you need to be booked off. After 728 days, it's no longer deemed as a sickness. Say, for example, our case study here, who is now sitting on a wheelchair, has been sick for many years and it's deemed not able to go back to work. So the first 2 years of them being sick, which is the 728 days, will actually pay the member for being sick. And this is a non-taxed, it's the money that's being paid is tax-free. It's not taxed and it doesn't take into consideration the fact that you are still receiving an income from your employer. So it's over and above what you're receiving. We will not ask you for proof of loss of income to say, listen, you need to show us that you're not getting anything for you to be eligible for this claim. It doesn't work like that. For as long as the doctor comes in and they say that you are booked off and you're deemed unable to perform your normal duties, it is a valid claim. After 728 days, we no longer see it as a sickness benefit. So the first 2 years, you're most probably going to be submitting a sickness claim every month. And then after the 2 years, you're not going to be required to submit a sickness claim anymore. You are automatically being put on what we call a permanent incapacity, meaning that you will be receiving however much money you were covered for for the next, if you chose maybe a retirement age of 60, 65, 70, or a whole of life. So I'm just going to use case study A. Let's say, for example, you were insured for a salary of about, that you're going to be receiving 70,000 every month, and you were paying a certain amount on a monthly basis. If deemed now unable to work and you're permanently incapacitated, you will continue to receive that 70,000 tax-free until age 60, 70, or if you've chosen that you will be working for whole of life, until the day you pass away, you will be receiving that, that income. It's a very good product. The nice thing is it takes into consideration two different patterns. You can either choose a level rated premium, which is, it starts off a bit more expensive, and as the years progresses, it becomes cheaper. Or you can either choose an age rated, which starts off expensive. It starts off cheaper because you're younger, but as you grow older, it becomes more expensive. The sickness benefit is also differentiated by gender. So you'll find our female members actually do pay more than our male members. And you'll see the reason why. I'm just going to explain the reason why. And then it's also determined by your smoking status. So you'll see our smokers actually pay more because of their risk. You know, a sickness for a smoker, for example, if you contract something, it's going to take longer for you to recover. So the sickness benefit actually covers 100% of a member's earning ability, considering the impact of the sickness and the injury. And the benefit is designed to support the graduate professional throughout their whole process, their whole working process of being sick and being permanently incapacitated. Like I said, the first 2 years are a sickness. After 2 years, after the 728 days, you are deemed to be permanently incapacitated, and you will be receiving that award until whatever age of retirement you have requested. And I did say that our female members actually tend to pay more than our male members, and this is because the sickness benefit actually has a pregnancy related sickness benefit incorporated in it. So each and every single female member at PPS has what we call a pregnancy complication cover incorporated into that a sickness benefit. So this covers your, for example, if a member is deemed pregnant, or not deemed pregnant, but announces that they are pregnant, and they are now sick or experience any complications. This includes your C-section, whether it be selective or emergency, you will be covered. And you know, with the pregnancy, when you are in when you go through a C-section, you actually are booked off for about 6 weeks. Even though you are on maternity leave, you can submit a claim for that C-section that you went through. So that's why I'm saying we do not aggregate, meaning that we do not ask you for proof of loss of income. So you'll be receiving your maternity benefit and still be receiving the benefit of your claim from PPS, which is part of the pregnancy complication cover. So the sickness benefit is quite a versatile product in the terms that it's got what we call the permanent incapacity booster. So the permanent incapacity booster says after the 728 days of you being deemed sick with the same condition, automatically we kickstart your permanent incapacity to 100%. So that's why we call it a booster, and it's non-reviewable. We can't go back. Once we've awarded you the permanent incapacity to say, listen, you will continue receiving this amount of money for the next 15 years or 20 years of you being sick or permanently incapacitated, we cannot go back after 5 years and review it. So it's non-reviewable. So that pushes your claim up to what we call 100% claim. Then advisors normally advise the clients to take out the booster, because it avoids the issue of having to get an assessment, you know, and this is on an issue, you pay a little bit extra for the booster so that you don't have to go through all those assessments of whether you are now recovering or not. So the booster actually takes your payout to 100% non-reviewable. And then we're going back to the admission rider benefit. The admission rider benefit says, listen, case study A, you are sick and you are hospitalized for longer than 4 days. You're actually receiving a double pay, the mere fact that you are all sick and you are in hospital. So the first one, like I said, just being sick, you don't have to be hospitalized, it's already a claim. And you being sick and being hospitalized actually means that you're getting a double pay. I get very excited when I talk about this product because I've also had a share of being in hospital and having to claim from the sickness benefit. It's actually, it helps out because some of that money you can use towards paying off whatever outstanding fees that you have with the hospital. And I must reiterate that this is not a medical aid cover. It's not like a medical aid that pays the hospital. It's money that is paid to you in your bank account for you to be able to continue with your day-to-day life of paying for your expenses, making sure that your life continues running effectively. I'm going to go in again and talk about the family responsibility rider benefit. So that one is quite nice. We're saying now the member is not sick themselves. So this is an additional benefit. That's why it's called a rider benefit. It's actually extra that you pay for. So this is when the member is actually not sick. Remember, even your family members being sick, your child, your husband being sick, it's kind of a financial strain because now you have to spend time, especially when the kids are sick, they get booked into the hospital. Now you must also take time off from work to go be with them at the hospital. So we're saying to the members, rest assured, if your child or your spouse is hospitalized due to any type of sickness, as long as they're in hospital for longer than 3 days, they can actually claim from the family responsibility rider benefit. And this can be claimed for up to 90 days in a 12 months calendar. So only 3 months in a year can you claim from this family responsibility benefit. So like I said from the beginning, this is not a medical aid scheme, and the cover is not the same as that of a medical scheme. This policy is not, it doesn't substitute your medical aid. So it's more, it's over and above what you are already receiving from your medical aid. And it's one of our favorite, I actually call it our flagship at PPS. And I always say, even if you don't take any of the stuff that we have at PPS, our life policies, it's always advisable for you to take out the sickness benefit. I've seen people benefit from this, and I'm thinking now our case study here will actually benefit from this benefit to such an extent that they don't have to worry about whether the employer pays them or not, because then you actually getting your full salary from your insurance, and it's that 2 years of being sick, and after 2 years you can literally be at home and not be bothered to go back to work, and now having to have the stress of being accommodated, sympathy at work. Now you're being sympathy employment. You don't have to go through any of those things. If you decide to say, listen, I'm done, guys, I'm sick now, I need to focus on getting better, you can somewhere do that, lay down the weapons and be at home, and you'll still get your salary. Okay, another thing that we have at PPS that's actually related to the topic of today is what we call the PPS Professional Disability Provider. Remember what I said with the sickness benefit? It pays you like an income. So it pays you on a monthly basis. So if you were covered for that 70,000, every month on the 25th of each month, you will receive the 70,000 tax-free. The disability cover, however, on the other side says, like case study from today, will receive that 70,000. If let's say, for example, the way they took out a disability cover of let's say 2 million disability cover in an event that they are unable to work, and they took out the benefits of taking out the boosters as well on the disability. The disability will pay a lump sum amount. So this is a lump sum payout that is given to the member to adjust their life. So for example, our case study now is on a wheelchair. This guy will need to adjust, maybe get a wheelchair-friendly car, adjust the house, include some ramps inside, make sure that this is a life-changing event. Your disability will pay out a lump sum, which is about, if you took out the 2 million. So the professional disability providers offers you 2 options to cover from. So it's either you get your occupational disability provider, which is a standalone lump sum benefit that pays out should a member become occupationally disabled. The benefit will pay out 100%. So if you were covered for 2 million, it will pay you that 2 million lump sum upfront, and just so that you can adjust your life. And then the second one is the functional disability provider. So this one is also a standalone lump sum benefit that will pay you should the member suffer from a listed functional disability. So this one will vary. It will look at the severity of the disability. So whether you still can do 25%, 50 or 75% of your usual day-to-day duties, it will pay you accordingly. So members can choose to be covered for either or both. I know from my side as a PPS member, I've taken both occupational disability, meaning that I can still do my normal day-to-day duties, or whether functional meaning that I can still sit at a desk. Someone said something about now you can't do the lifting of the heavy objects. We will now put you into, you're merchandise, now you are a teller. So those type of things to say, listen, can I still do my day-to-day? If I studied as a lawyer, can I still practice as a lawyer, or can I only do what we call administrative work? So I always say it's very important for one to get either one, but I always recommend that the sickness benefit, because either way, you are sick, you are disabled or critically ill, you are still sick, and you will be needing some form of money on a monthly basis. So the disability, I always flag it out because it's nice to have a lump sum amount pay out so that you can adjust your day-to-day. And then lastly, I look at the critical illness cover. Critical illness cover is basically you being deemed critically ill, who suffers a stroke, you suffer a heart attack, cancer. I know a colleague of mine that was actually working with us was diagnosed with cancer, colon cancer, and she was put on the company's disability. But I mean, it wasn't enough because it wasn't paying her the same amount that she was earning, which was earning a cost to company plus her commission. But now on the company disability, the amount that she was getting, there was not even a match. And lucky for her, she was on the company's critical illness insurance on the side, or on personal capacity. So that also paid out. And that's a lump sum amount that you receive for her chemos and all of that, because that was a very expensive exercise. There were certain things that certain procedures where the medical aid refused to pay, and the money actually came in handy, because this is also a lump sum amount that the member can receive for suffering a listed trauma, physical impairment, or critically illness condition. So those heart attacks, the strokes, the cancers, it actually pays out a lump sum. Okay, so you can choose the benefits. We always, our financial advisors always recommend the Core 100. It's either you can choose the Core 100, the CI 100, or the catch-all option. So when you sit down with a financial advisor, they actually explain everything. We always recommend now the CI 100 to say, listen, it pushes your claim up to 100% payout without any reviews. And the catch-all says, we didn't know about COVID, we didn't know about cow disease or chicken disease back then. And now all of a sudden we have what we call smallpox or whatever. Now there's a new disease that is now here, you covered for it. The critical illness also covers what we call the child critical illness cover. So I always say that insurance is actually the embodiment of preparedness. It offers a safety net when life takes an unexpected turn. So our financial advisor, Mrs. Khomotso Letlape, is actually accredited to give proper financial advice on all the products that I've now spoken about. You can take down this number or take a picture of the screen, and you can be in contact with her regarding your assistance in terms of getting on board with PPS and making sure that you become a member of PPS and you have all these products that we are offering at PPS. Thank you so much, Dr. Mkhwanazi. Any questions?
Yes, thank you, Rebecca. Many questions. Let's get this out of the way first. Colleagues, there's something wrong with our clocks. It says 8 o'clock, but it's actually 10 to 8. So that means if you agree with me, we still have about 10 minutes for questions. Ausi Khomotso, are you there? Khomotso? Hello?
Just check if just unmute yourself, Khomotso.
Yes, I have a very important question that usually comes up whenever we talk about disability and incapacity, impairment. while Humutso is joining. The difference between temporary incapacity, permanent incapacity, and medical boarding. Are you there, Humutso?
I think she dropped us.
Okay, she's been answering questions in the group.
Okay.
But either way, it's not a problem. Humutso, please just let us know once you are back. I don't know if you are struggling to connect. So thank you very much, Rebecca. This was very informative. It makes me feel like I need to be incapacitated right now, but for obvious reasons. For obvious reasons, I'll hold on a little bit longer. Colleagues, I see you've been asking questions, and we've tried by all means, knowing that this was a jam-packed session, we've tried by all means to answer as many as possible. Please feel free to continue asking questions. I'll get you the answers and I'll post them on our YouTube channel together with the video of the session today. And then I wanted to say that I hope you realize how much we need to love our jobs and how much impact we are making in people's lives. And I want to urge you to please continue learning. And I want to thank all our speakers today for sharing this knowledge with us. You know, sometimes these are things that we never even bother ourselves with. And in our next session, colleagues, we are going to be a bit controversial. We'll be dealing with employees with ancestral callings. You know, I'm sure some of us have dealt with one or two employee who comes to the clinic and says, "Doc, my ancestors wants me to be away for 6 weeks because I need to go to Hasa or I need to go do some rituals." And most of the times we refer them to LRA or BCEA or many other laws that have, you know, mnemonics, you know, these laws that when it's hectic, you stop saying Labor Relations Act, you say LRA, you know, according to LRA, this is wrong. And so once again, I would like to thank everybody for attending and lasting for this long. I would also like to thank Ms. Ingeborg, Sister Margaret, House Rebecca, and Nicole. And if any question arises that we are not able to answer, I'll forward your questions to them. And I'm just checking one last time if Omoto is around.
Yes, I'm here, Doctor.
Yes, Omoto. There
So
are
sorry, I was struggling to unmute myself. It was
no
disabled
worries.
on my side.
Don't stress
Yes.
about it. There are 87 people still online who wants to know what is the difference between medical boarding, temporary incapacity, and permanent incapacity.
Okay, so I'm gonna answer the one for temporary incapacity and the permanent incapacity. So when a member or a client is deemed to be temporarily incapacitated, it basically means that they can still perform some of their duties, but not like fully. So with regards to permanent incapacity, it means that one cannot perform their duties completely. So one thing that Rebecca also mentioned with regards to the income protector earlier is that our PPS income protector, it does cover for sickness, partial and permanent incapacity. And we do not aggregate. We always get a question from people in the public sector saying, okay, since I'm on sick leave, I'm still gonna get a salary. Are you guys gonna aggregate against that? It's your money. It's got nothing to do with us. Our job is to make sure that you are not financially inconvenienced during that time that you get sick. Because if we are being realistic, if let's say, for instance, you're getting paid 100K per month, you're surviving on 100K, there's nothing wrong with you physically. But the minute you get sick, you will need more money, regardless of the fact that you have a medical aid or not. So financially, either way, you're gonna be inconvenienced. And at times, we find out that you got sick, you got booked off, and you exhausted your sick leave. Personally, I work, I'm not just a salesperson at PPS. I work very close with my client, meaning I do help my clients with claims. I had a case whereby a senior auditor was left with 6 days sick leave, and they were booked off for 21 days. They actually got bitten by a spider when they went home during Easter. It was nothing serious. Next thing they came back, it started becoming a big thing. Next thing, a person is in ICU. They had to drain the abscess, stuff like that. So the client was so scared of, oh my word, how am I gonna pay my bond? How am I gonna pay for my car? I only have 6 days left of sick leave. And PPS actually paid for those 21 days that the member was booked off. Mind you, the time that she joined PPS, actually signed her, it was around 2018 June. And she was supposed to pay her first premium on the 15th of August because she works for government. PPS, when we gave her the cover, we said, member, we are giving you a free month cover. So when she had to claim, PPS didn't say, no, you haven't even paid your first premium. We had to honor our promise because that's what we promised to the members. So when you're starting, we're gonna give you a free 30 days because as graduate professionals, we know that the minute we come to you and offer you this product, majority of you guys, you already have products with other insurance companies. Some they don't have. So everyone will get the thing. And then another nice thing about the PPS Income Protector is the fact that 30% of over 30% of the premiums that you're paying on the Income Protector, they are going to your profit share. I had a question here. Someone who's an radiographer, they were asking that why am I not qualifying? Because the old qualification was 3 years, now it's 4 years. Unfortunately, with regards to the membership requirements, we are very strict. Reason being, once you get to PPS, once you join PPS and get PPS product, you don't just become a client. We also share the profits with you guys, because with other insurance, what they do, they collect your premium, they only pay you when you get sick. At PPS, whether you claim or you don't claim, those premiums, they are working for you. And we don't even have those conditions saying, member X, if you don't claim for 5 years, we're gonna give you this and this back. Whether you claim or you don't claim, you still benefit. I also had I saw a question whereby Chucky did say that she did claim in December, there was no payout. You also need to bear in mind, like I always tell clients, or it's always best to deal directly with somebody who works for PPS. I'm not painting bad brokers and stuff, but you must also remember, if I work directly for PPS, it means whenever there's new products coming in, we are the first ones to get trained on. If you go get somebody who specializes with different insurance company, they do know the products, but they don't know the products like people working directly for PPS. Usually with the claim process, you submit your claim, your financial advisor's job is to make sure that the forms are filled in correctly, help you to fix this and that, because if your dates are wrong on your claim form, we won't pay. The claim will be returned. So usually when you're submitting a claim, you should get feedback within 5 to 8 working days, catching into your bank account, no issues, nobody's gonna monitor you, how are you using your money? It's your money. Like Rebecca said, it's not a medical aid. So when you claim, we give you the money directly into your bank account. What you do with the money, it's up to you. Also, Peter did ask if we do exclusions to existing conditions. That one is it's honestly dependent on the underwriter. A client can come in and say, I've got hypertension, but it's controlled. And PPS can just issue your benefits without any loadings or any exclusions, because we differ, situations differ, medical conditions differ. So I can't say you're gonna get a loading, you're gonna get an exclusion. That will be solely dependent on the underwriter. And then again, the nicest thing about, because Rebecca also touched on critical illness, and we were talking more on disability earlier on. The nicest thing about this Income Protector, you get a person getting diagnosed with cancer. Obviously, cancer will pay under critical illness. Obviously, you get a lump sum payout. And then the rule of Income Protector says, if we pay you your monthly salary for an illness for 2 consecutive years, for two consecutive years, a month 25, we're gonna declare you disabled. Even if you're not you're physically able, everything is fine with you. For the mere fact that you were diagnosed with cancer, you survived 2 years, we're gonna declare you disabled, meaning from the onset when you get cancer, let's say your critical illness was sitting at 3.2 million. We give you 3.2 million. That 2 years, we're gonna pay you your monthly salary to what you have been covered for. If let's say you were covered for 100K, you're gonna get 3.2 million, which is a once off under critical illness. And then monthly, you're gonna get 100,000 every month, tax-free. Month 25, you still haven't recovered, you're still alive, nothing has happened. We declare you incapacitated according to the income protector, meaning you won't be paying for the premiums of your income protector. And on top of that, we have to pay you another payout under disability. Remember, there's nothing wrong with you physically. You just have an illness. You just have a chronic condition. If let's say your disability was sitting at 4 million, now that means after 2 years, after you got that 3.2 million from critical illness, we have to give you the lump sum for disability. And that again, you won't be paying for your income protector premiums because there is no salary to protect. And obviously on the employer side, your employer will also let you off because no employer will pay you an income for 2 years while you're sitting at home doing nothing. And with that being said, I know it's happening. I've got one client who's on that. They were diagnosed with cancer February 2018, and the doctors told him he's gonna die in 2019. He's 57 this year. He's a chartered accountant. We're always talking about the interest rates and stuff. He is still very much alive. He got his lump sum 2018 for cancer. And then 2021, we declared him incapacitated. He got an extra lump sum. Now he's just chilling at home, enjoying his monthly salary, no debts, nothing. He can even afford the chemo. Remember, the doctor said he's gonna pass on in 2019. So for you to also avoid being a financially burden to your family, having an income protector and a disability cover and critical illness is of utmost important, because sometimes clients, they do ask us, Pomoto, why do you think I need income protector and disability? Can I not take one? Honestly, you can take whatever that you want to take, but both are important because the minute a person is declared disabled, your needs changes. Firstly, you've got a house that you are probably paying with your salary. You need to pay that off. You need a lump sum. You can't use your salary monthly to pay off for the bond. You need a lump sum. That's where a lump sum disability payout comes in. You also need to pay off your car if your car was still owing. You need money to do some modification to that car. I always tell clients, have you ever, when you're at the mall, have you ever been that curious and asked anyone who's parked in the disability parking thing and ask them how to see their cars inside? It's very expensive. It costs so much money to modify a car. You won't need just the salary to do those property adaptations and modification to the car. That's where you will use your disability lump sum, and PPS will still continue giving you a monthly salary, meaning you can still continue living your life without being a burden to anyone. Same applies to the critical illness. And with regards to our employers, we do have group life. Yes, group life is important, but what most employees do not realize is that group life on the life cover, you do get sufficient enough. But if you go check your contract, you check your disability income, your employer is probably covering 75% of your income. If something happens to you today, you become disabled, God forbid, who's gonna give you the other 25%? And how long are you gonna get that income? Because like I said, no employer will say, okay, Mr. X has been disabled, has not been working for 2 years. Let me just continue giving him the salary for life. They can only cover that much. In most cases, group life, they can only give you up to twice your annual salary. Then you are on your own. You are on your own. So yeah, considering taking income protector, disability, and critical illness privately, it's very important. It's very important because group life, it doesn't touch that at all.
Thank you.
Okay. I
I
hope
have
I
no
wasn't
questions.
talking
You've
fast.
answered all the questions that I had in one long answer. And I am only left with one thing to say, and that's thank you. And I think your phone will be buzzing tomorrow or going forward, because we all realize that we have adjustments to make. And yeah, any closing statements before we adjourn?
Okay, and then also, what I forgot to say is that I see we have PPS proud members who have been with us for over 27 years, for over 20 years. Thank you so much. And Chaki, kindly connect with me when we're done. I would like to help you with your claim and see what was the hold up. And anyone who has been a PPS member for years and haven't been serviced in more than a year, I am happy to assist you with your products. Because remember, again, you might have signed up 10 years ago, your salary has changed. The last thing that you want is to get sick and we pay you peanuts just because you were not adequately covered. So feel free to contact me. I will be happy to assist you. Chaki, I will be waiting for your WhatsApp or your call. I would really love to assist you with your case. Thank you so much, Doctor.
Thank you very much, Auskomotso. And colleagues, on that note, we are leaving it here until we meet again on the 28th of August, when we'll be talking ukuthwasa amadlozi, bogogo, nabokhehla, and whatever else that comes in between. Thank you very much and good night.